this is quite an important subject because it causes a lot of mortality in the under 5s. I think it is around 9% of the total under 5 mortality, which is caused by neonatal infections. And in the neonatal mortality, it is the 3rd most important cause of death after prematurity and asphyxia. What we see in our facilities, I think, is only the tip of the iceberg. There will be a lot of neonatal mortality in the community. And as still most women deliver at home, there is a lot that we won't see. So prevention is something that is very important. And what are ways to prevent neonatal infection? The more so because the diagnosis of neonatal infection is quite difficult. We are all aware that the signs of neonatal sepsis are very subtle, and diagnosing neonatal sepsis is not an easy thing. And then the treatment of neonatal infections is also quite difficult, especially in the light of the growing antimicrobial resistance that is there. So it gets more and more complicated. And as we as MSF are advancing in our levels of care, the levels of care have been mentioned frequently during these days, and we've seen that we are advancing, we are introducing new methods to increase neonatal survival. We add CPAP to our treatment options. The more we advance and put children together in neonatal wards that are getting to be high-tech sometimes, the more we have the risk of introducing infections that we sometimes find very difficult to treat. So that's why I think we will have a very interesting session, starting with the presentation of Ulrike Müller, who is a German pediatrician who has been just finished her 3rd mission for MSF. She worked before in Haiti, and in Haiti, MSF OCA has this advanced level of care neonatal unit. And Uli will discuss the problems we had there. Uli, thank you.
So today I want to take you on a virtual trip to the beautiful island of Haiti. And unfortunately, Haiti is not only known for its beautiful beaches and the good rum, the Creole culture and the strong people, but also for the devastating earthquake in 2010 and a long history of political instability. So I arrived in Haiti in December 2014, ready to start my work as a pediatrician in one of the 3 OCA projects in Haiti, the CRUO in Delma. Let me tell you a bit about CRUO. CRUO is a secondary care structure dedicated to women with obstetric emergencies, mainly preeclampsia and eclampsia. So meaning there we don't do normal deliveries, but just complicated deliveries and women who are in desperate situations. Since 2011, OCA is running the hospital in a container-based structure. CRUO stands for Centre de Référence Urgence Obstétrique, Emergency Obstetric Care, and that is the one and only focus of that project also. In 2014, a total of 6,229 women delivered in CRUO. Where there's a sick mom, you know there's usually a baby being born premature or sick. So in CRUO per month, between 200 and 300 babies are admitted to the neonatal department. In 2014, a total of 2,649 babies were born in CRUO. Especially during the so-called peak season, which follows the extensive carnival festivities, which goes from September to January, the neonatal department was often overcrowded. And over the years, it grew massively from a 5-bed unit to now a 60-bed unit, which is often not even sufficient, with a big pediatric team. So when I arrived there, I was impressed to find for MSF standard rather well-equipped department. We had 5 old Draeger incubators, we had 3 Pumani rice CPAP machines. The team was really motivated and also very experienced. So I thought, okay, that's a nice country, team is friendly, work is interesting, that should be a rather easy job. What I didn't fully realize at that moment, but then quickly learned during my briefings and handover, was that the CRYO was facing massive problems at that time. From July 2014 on, the mortality rate was spiking up. It usually has been at around 10 to 15%, and now it came up to 30%. What the doctors and nurses did observe from July 2014, so well before my arrival on, was that the presentation of the sepsis cases was rather different to earlier cases. They talked a lot about the mauve teint, meaning not only the prolonged capillary refill, but also a slightly greenish appearance of the baby's skin. Also, they talked about the sclerem, a term I have never heard before, meaning a certain redness, thickness of the skin. So, after the mortality had gone up in July, the team had already massively worked on improving hygiene procedures, followed by a decline in cases. But unfortunately, after the birthing peak had hit CRYO again, the numbers climbed up again, and from October until the end of November, the mortality rate was sky high again. At the end of November, the numbers came down, so when I arrived, I found a rather seemingly more or less stable situation. So I thought, okay, we take it from there now. Only a few days later, at the beginning of January, I realized that I was wrong. The mortality rate came up again, and I witnessed many patients who were primarily stable dying of presumably nosocomial sepsis. My predecessor had already started taking some blood cultures, which we intensified and continued now, and fortunately in Port-au-Prince there's a highly qualified microbiology lab available. The results we received were rather shocking. Most of the blood cultures came back positive for Klebsiella pneumonia ESBL. So together with the medical team, the MEDCO and the epidemiologist, we made a rapid action plan. We started establishing the so-called septicemia line list, which didn't include only all babies getting sick from the beginning of January, but also went back to a previously existing data collection in October. And by extensive chart review, we managed retrospectively to get an idea also from what was happening already since July 2014. In addition, now we routinely took blood cultures on all septic patients, and whenever the blood culture by peripheral venous access was not possible, we took perianal swabs to see if the baby was colonized at least. So with that data collection, we now got a better idea about what was happening. The analysis we did was really concerning. It confirmed that we were facing a massive outbreak of Klebsiella pneumonia ESBL. You see on that graph that basically the main risk factors for attraping a sepsis would be gestational age and birth weight. And as we all know, the smaller the baby and the younger the baby, the more immature the baby, the more likely it is to get sepsis. So no big surprise there, but just the total number of cases was the shocking fact. So what shall we do now? Shall we close the whole hospital, or at least the neonatal department, as this was done in some European centers who faced similar outbreaks? But what about the mums then? If the mums wouldn't have any other place to get care, because in Port-au-Prince at that time, CRYO was the only center who was fully functioning and able to treat preeclampsia, eclampsia, and also to perform C-section 24/7. If we now would close the hospital and wouldn't treat the mums would lose. If we treat the mums but have no facility to treat the babies, then for sure all those premature babies wouldn't have any chance of survival. So right in that dilemma, our headquarters took the decision to send us 3 specialists from Europe. One was a microbiologist, one epidemiologist, and one infectious control specialist. So together with them, we realized a first prevalence screening, including all the 3 rooms of CRYO, and sent it for analysis to that microbiology lab. And the result we got was that 31.4% of all the babies in our pediatric ward were colonized with that Klebsiella ESBL. The team of specialists also couldn't really help us to find one single source, but they helped us identify like the main issues. You must imagine at that moment, the team had already put much effort in improving infectious control measures. It's not like we started from zero, but despite all those efforts, we were still in that desperate situation. So now we got some guidance on how to continue. Together with them, we came up with 10 priorities. We also incorporated some ideas we got from our literature review there. So here are the original 10 priorities. First of all, as you all know, hand hygiene is essential. We started to encourage use of alcohol gel, which was already available at that time, but not so frequently used. The paper towel dispenser stands for not only hand washing, but also drying the hands and not touching all the surfaces with dirty hands. A huge factor was also the preparation of IV medication and IV fluids, because you can imagine in a unit with 60 babies, out of those 15 intensive care, well, at least 15 intensive care, around 30 intermediate care, and the rest in the kangaroo unit. You can imagine the amount of IV medication and IV fluids the nurses had to prepare every day. Also, we worked on improving the storage of breast milk and the preparation of artificial milk, because some few babies were also on artificial milk. We avoided stagnant, non-sterile water in our incubators, because at that time our old broken incubators had a kind of an open water source where you fill in the sterile water, but then it kind of was left there for days and days. So this source we wanted to avoid. Another one was the better organization of the rooms and cleaning practices for our hygienist team. Because when I came there, the rooms were rather chaotic and cartoon boxes on the ground, and it was difficult really to really clean the floor properly and also to find something simply. Sixth point was we wanted to avoid the multiple use of sterile material, rather go for mono-use, and if possible, like all equipment which could be sterilized, we sterilized. So for the CPAP equipment, for example, we had mono-use, but just for the tubing, which were also those silicone tubes we saw earlier, those were sterilized, for example. And for the suction devices, we used to have some rubber bulbs, which you couldn't really clean properly. You always had some air resting in there. So those were now substituted by the suction device, that penguin you see there, which can easily opened, cleaned, and then sterilized. Another point was cleaning and washing of linen. So don't keep the linen open everywhere for days and days. And also wash it at proper temperature. Another very important point in my point of view is the point that the babies shouldn't be contaminating each other. So before on the admission table, you often had 2, 3, or even 4 babies lying there. Although the admission table is not very big, and also you see it's slightly broken there. So now we made it a rule that there should be only 1 baby lying there at a time, maximum twins, because they were in the same uterus anyway. So, and also we were aiming for some new, more modern admission table, which could be easily cleanable. We rethought our system of isolation of sepsis cases. We made first a separate corner and later on a separate room. And the nurses had blouses when caring for the kids to avoid transmission. And last point, we were aiming for a new air condition which should be up to OT standard, and which we think also should make a big impact. So those 10 points might first seem as rather small things, but for us it was quite a useful checklist. So with that checklist, we couldn't only motivate the team, but also include the logistic and the supply team to support us strongly in the daily activities. So to those 10 priorities, we later added more points. One very important point, the bed occupancy rate should always stay beneath 95%. That needed some adjustment in the general running of the hospital. So the admission criteria for both mums and babies were revised. Secondly, the antibiotic treatment protocol was revised. So after amikacin was already added as second-line drug in October 2014, we now came up with the decision to also make meropenem available for sepsis cases to increase the survival rate of those. And the planning of the construction of a new block was pushed forward. The new block, as it was called, would not only allow a better patient flow, because the pediatric department would be in one setup and not many rooms spread all over the hospitals, but it would also give better conditions in terms of cleanable surfaces. So you see the block at the moment of inauguration in December 2015, and you also see kind of the material we had there. So that's a huge difference to the previous setup where the babies were spread out all over the hospital. As we heard before, supervision and training and enough human resources are always essential, especially if you want to fight against nosocomial infection. So first of all, we strengthened supervision by adding national staff supervisors and also an expert pediatric nurse. And the national staff supervisors, because before one nurse was supervising 40, 45 other people, so she was busy with planning and all, HR issues. So now we had a so-called nurse clinic who are focusing strongly on clinical care and also on infectious control measures and helping their colleague to improve their techniques. But also the HR planning for doctors and nurses was adjusted, because if you want to avoid overcrowding, you need to have a good functioning patient flow. And if you want to have a good patient flow, you need to make discharges as early as somehow possible. And the babies need to go out of the ICU as early as possible and move via the kangaroo mother care, if you want to call it like this, as early as possible. So therefore, there shouldn't only be once or twice daily ward rounds, but also more checks throughout the days and more regular ward rounds, and to really make sure every child is advancing in its care as fast as possible. To strengthen kangaroo mother care, we also worked on our collaboration with a local partner, a government hospital. So we helped them to set up their kangaroo mother care unit, so afterwards we could transfer some of our patients to their unit. So the moms really appreciated that, because if they came from that part of town, they now had the chance to continue weeks of kangaroo care very close to their home. And it helped us because we could empty some beds a bit earlier. And of course, also it spreaded the knowledge, because the kangaroo mother care was already accepted in Haiti, but not really so widespread. What we also did is we repeated our prevalence screenings every 2 months to just see how it went in terms of colonization of the patients, and to determine if we are facing a real outbreak. A genetic testing of our Klebsiella pneumonia ESBL was done. So actually the genetic testing confirmed that out of 15 samples sent, 9 were exactly the same genetical strain, ST37, which has been known to cause outbreaks in many different countries. So basically our bacteria was all a clone of the same original bacteria, which then was spread all over the world. To coordinate all these activities, we founded a so-called septicemia committee. So in that committee, we didn't only include the pediatricians and the nurse supervisors, but also the pharmacists, the logistics, the supply, just to make sure we were all on the same page. We could spread information easily, and we could share updates on the improvements we made. All decisions and experiences we made were recorded in a so-called septicemia diary, just to also facilitate our communication with coordination and headquarters. So, hearing all this, you can imagine how much that whole battle against Klebsiella influenced the running of that hospital. It basically, for a few months, everything was about that battle. So let's see what impact it had. You do see here that the number of cases did go down quite considerably until September 2015. And you also see that the case fatality ratio decreased significantly. But I must admit, unfortunately, that positive trend didn't continue forever. So after the peak hit again in October 2015, from end of November, beginning December on, more cases were observed. First of all, we did observe a massive increase on colonization. After we were really celebrating in September, so now in December you see the colonization rate of babies was higher than ever, despite all these measures. And consecutively, because of that higher colonization, we also did see more cases and a higher mortality rate again. I'm just presenting data up to December 2015 because that's the time I spent there, 1 year, to kind of, and that's the time I can tell best about because I've been there myself. So, of course, this is very frustrating, but I think also the positive changes overall cannot be denied. And if you compare the graphs from 2014 and 2015, you see that mortality rate was much lower, and still I think we made quite some good changes. What I can assure you is that the team which is there at the moment is still continuing that battle. This year they are strongly focusing on individual patient zones. Like before, we already were respecting at least 1.20 meters between two babies' beds, but now they are rather working on where do I put the equipment. This equipment is only for this baby, and specifically also putting more focus on avoiding contamination by shared materials. If possible, there should be materials only used for one baby, like in Western ICUs, but some, like the saturometer, obviously is still be shared between several babies. And disinfection was already practiced before, but this is things that really needs constant reminders, otherwise you see neglect again. So sharing that experience in Cryo, we, the team in Haiti, and the, as we call it, outbreak response group, want to call MSF to action to come together to standardize infectious control measures, especially in neonatology. Those patients are the most vulnerable of all, and in a resource-limited setting, neonatology is, as you know, a very difficult issue. I think one needs to think very carefully how much care you can provide for those patients without putting additional risks. Like, first of all, do no harm. So, still, I think that example can also be taken to other group of patients, like malnourished kids or burned victims. So we just wanted to share our experience to learn together from it. So I'm passing on the greetings from the team in Haiti, and I thank you very much for your attention.
Thank you very much, Uli, for presenting us this struggle from a few years in 20 minutes. There is time for some questions for clarification at this moment. Monica. We have
yeah, thanks. This was really great. I think this, all of us who've been to the field, I think we've seen patients with dying of infections that we can't treat. And I really, really hope MSF can draw learnings from this and improve quality. I was wondering, because you had the ESBL, did you change the antibiotic regimen in any way from standard MSF protocols?
Yeah, we did adapt. So basically, when the first cultures came back for Klebsiella pneumonia ESBL already in October 2014, the treatment protocol was changed to amikacin as second line, but at first only one line amikacin, later combined with ampicillin. And we kept that as second line, but when we saw more sepsis cases and saw also a high mortality rate, we took the decision together with the microbiologist to add meropenem, also a third line. Obviously, it isn't the long-term solution to just take stronger and stronger antibiotics, but still at that moment, to save more children, while all the other actions were ongoing, seemed reasonable, so meropenem was made available, and we started using it in March 2015.
One more question there, and then there, and then there.
Thank you very much. I'm very impressed. What I was thinking about, we had a similar situation in Stockholm. It's the same, trying to work on so many different levels. One experience was that as long as the outbreak was going on, it was much easier to get all the staffs and parents and everybody to follow the hygiene routines. But then at once when we thought it was getting better, then people tend to forget. Was it the same experience you had? Could that be the reason why it came back? Any ideas how you can handle that situation?
I do think that's quite a universal problem. So first of all, I think the hygiene standards were not like extremely bad when we started, but obviously not sufficient for neonatal ICU. So with all that information about Klebsiella, we had meetings, trainings, lots of materials, lots of support, whatever. Obviously, people became more aware. And we did intensive training, like also the fluorescent light, looking at your hands, hand-washing technique, and all that stuff you do in Western countries. And of course, the team was motivated and made really an effort. But also, at least I think as far as I'm aware, in Europe, like in all centers, people are aware that hygiene is a massive issue, and in the neonatal ICU you need to be very careful. In Haiti, we did have, in my opinion, a little bit the additional problem that people felt also like, why do we have that problem? And in other government hospitals, they don't have that problem. And now why is MSF making such a fuss about hand hygiene? And insisting so much on the alcohol gel, and I have to take off my wedding ring, and I have to take off my nail polish. The nail polish was my biggest enemy. But so basically, because they felt like in the government hospitals there was no problem, which is obviously not true. They just didn't have as many kids, and they didn't publish or communicate on the deaths. And there is even some, if you do PubMed research, you even find very old articles from Haiti, from government hospitals where they had outbreaks already 20 years back. It just wasn't communicated as such. But for them, it felt a bit like now we are making such a big fuss and we are probably exaggerating there a little bit. But I mean, lots of discussion, we got them on board, and then after they saw the success, and the success was also shared every week, like this week it went like this, there were some weeks without even a single child getting sick of sepsis, they got more and more motivated, and that carried on for some time. I still think with the peak and the higher workload, the motivation obviously dropped a bit, and there was still some neglect of hygiene procedures. And also, as it is human, they also had a strong feeling to also search somebody who is guilty. So in some people's opinion, it might have been the dads who come in. Like the dad is bringing in the Klebsiella ESBL with his shoes. Or the moms are not washing their hands properly, which is true, but most likely us, the doctors and the nurses who touch all children all day long, are more likely a source of contamination than some dad coming in for 10 minutes to visit his baby. But I think that's a human thing, and it's quite universal, and I do think sufficient HR and constant supervision is the only way there.
I think we have time for 2 more questions. Not too long answers either.
Okay, thanks for your presentation and the good job, very good job in IT. I want to, for 2 questions. The first question is in relation of the link between infection and the way of delivery. On one of your slides, you show that you have more infection when you have C-sections. Can you explain why?
Yes, you refer to that tableau with the, yeah. So basically, the situation in Kryo, I think, is quite specific because 40% of all women admitted need a C-section. because there's such a high rate of complications and the women come so late. So 40% of all were like emergency C-section. We also had the feeling that maybe the way of the delivery could make a difference, but it didn't prove to be significant. And also one must say, basically, even if the child is born by C-section, it came into the hands of the pediatrician, for slowly, like for a second the midwife, but then immediately under the hands of the pediatrician. And as those were mainly small for gestational age and premature babies, it came in the hands of the pediatric team immediately. So I personally wouldn't say that there we could blame the OT or the gynecologist or the midwives doing vaginal deliveries. Because for the babies who have never been seen by the pediatric, not never, or have not been in touch with the pediatric department, there we saw a far lower colonization rate. I didn't show that, but also all over the hospital some screening was done.
There was another question there. No? One more question over there. The cholesterol resistance?
Yes. Have you seen any resistance?
Can you repeat it so that people hear?
How about the resistance pattern? Has it changed, I mean, over the time? And what is the prevalence of Klebsiella among the mothers when they are admitted? Do you know?
Yeah, so for the moms who came to our triage area, so for the emergency room for assessment, for those a screening was done, and some had Klebsiella pneumoniae, but we didn't find, at that time at least, we didn't find Klebsiella pneumoniae ESBL on the moms. For the cholesterol resistant, I don't remember exactly. I don't think there was a massive change, but what you did observe, of course, slightly resistance was growing, and in the end, it basically was only amikacin and imipenem which remained.